Good morning. I'm Pamela Bailey, a project coordinator at the Wilmot Cancer Institute. I want to say hello and welcome to this community conversation on cancer series presented by the Wilmot Cancer Institute's Office of Community Outreach, Engagement, and Disparities in collaboration with the Community Cancer Action Council, or the CCAC. This series brings information on cancer and cutting-edge care to both the community and healthcare providers, with a focus on health disparities. While COVID is not a cancer-specific topic, it does provide a spotlight on health disparities that affect the people in our area across all diseases. This live event has been approved for 1 AMA PRA Category 1 credit by the University of Rochester School of Medicine and Dentistry, accredited by the Accreditation Council for Continuing Medical Education. Throughout the following presentations, please feel free to enter any questions in the Q&A box located at the bottom of your screen. If you would like your question specifically directed to one of our speakers, please include the speaker's name in the question. And I will be assisting at the end to help moderate the Q&A session at the end of this presentation. I am now going to turn this over to one of our CCAC chairs, Dr. Candace Lucas. Thank you, Candace.
Thank you, Pamela. I'm so happy to be here with you today. I am one of the chairs of the CCAC. The CCAC is the Community Cancer Advisory Council. This council is made up of groups and individuals interested in working to lessen the burden of cancer within Wilmot's 27 county catchment area. Our mission is to bring together the community and Wilmot in order to improve cancer care from prevention through survivorship by empowering the community to identify their needs and assist in creating solutions. We focus on health disparities and the underlying inequities that cause them, and access to care issues to ensure that all communities and populations equitably share resources. And it is my privilege to introduce my colleague, Dr. Michael Mendoza, the Commissioner of Public Health for Monroe County. Dr. Michael Mendoza is the 9th Commissioner of Public Health for Monroe County. He is also appointed as Associate Professor at the University of Rochester in the Departments of Family Medicine, Public Health Sciences, and Nursing. Dr. Mendoza joined the Health Department in 2016. As Commissioner of Public Health, Dr. Mendoza's vision is to improve population health by strengthening the collaboration between clinical medicine and public health in our community. He has a particular focus in addressing the disparities in health and healthcare here in Monroe County. Prior to 2016, Dr. Mendoza served as Medical Director for Highland Family Medicine, one of the largest family medicine training practices in the country. He is board certified in family medicine and continues to see patients as a primary care physician at Highland Family Medicine. He also serves as a teaching physician on the inpatient service at Highland Hospital. He received his medical degree from the University of Chicago, his master's in public health from the University of Illinois, his master's in business administration from the Simon Business School at the University of Rochester, and his undergraduate degree in environmental studies also from the University of Chicago. He completed his graduate medical training at the University of California, San Francisco, and served an additional year as chief resident at the San Francisco General Hospital. He is an active member of the Rochester community, serving on the boards of directors of Willow Domestic Violence of Rochester, Common Ground Health, and the Rochester Rio. And he has faithfully and dedicatedly ushered us through this COVID pandemic. So with that, I want to turn it over to Dr. Mendoza.
Thank you very much, Dr. Lucas, for your kind words and for your partnership throughout all of this. We are, as we speak, still working on many projects together, and I'm very grateful for your partnership through all of that. I would like to spend the next 10-15 minutes or so sharing some thoughts, and I have some slides here that I think should work. Sharing some reflections on where we've been, where we are, and where we're going with regard to the COVID pandemic. Let's make that there. All right. So I think this crowd is no stranger to the reality that disparities in health and disparities in healthcare have persisted here in Rochester, here in Monroe County, and indeed across the country for many, many years, far too many. And I think if there's one good thing that might come out of this pandemic or even 2020, it's the recognition finally that this is a public health problem. That we have disparities has been well documented through numerous research studies, very rigorously done research studies, as well as the common experience of what people experience every day in communities like ours who purport to be at the forefront of leading efforts in diversity, equity, and inclusion. We have a long way to go. And I think it's important that we are in this conversation. I think COVID has shined a light on many of the disparities that have happened throughout the course of history. I think it has brought these to the forefront. And I also think that the ways in which we communicate about disparities have matured over the last year. In spite of all of the challenges that we've experienced in terms of how do we talk about race and poverty in this country, and how all of the events of 2020 and earlier this year in January have really ripped off the scab in so many ways of all of the hurt that has existed in many of our communities. I do feel that we are poised to do much better. I think we have to. I think if we get through this pandemic and not have seized the opportunity to shine a further light and actually do more around health disparities and healthcare disparities, I think that will have been the missed opportunity of a generation. So we have more work to do. I'm going to share with you some background statistics on how I view these disparities, where I think we need to go, and share a little bit about where we are with COVID, because I know that's a topic that's top of mind for many people. So this is a slide I presume many of you have seen. This is obviously Monroe County, and this highlights the disparity in life expectancy by zip code. Now, zip codes are complicated places, but we can pretty easily see here that the city of Rochester is disproportionately affected by having a lower life expectancy than the surrounding zip codes in Monroe County. And we know that the city is predominantly or much more higher in proportion in terms of Black and brown individuals. And when you look at it in numeric terms, when you look at the zip code 14608 and the zip code out in Pittsford 14534, you see almost a 9-year difference in life expectancy in one county that is ostensibly served by the same health systems, the same health department, the same government. And I think this is morally unacceptable, that we have this degree of disparities between two zip codes that are separated by 4 miles as the crow flies is unacceptable. In a country like ours that spends as much as we do in healthcare, that has the outcomes that we have in healthcare, this is not okay. And as much as we want to point to the federal government for payment reform and a whole host of other things that are largely out of our control, there is more that we should and can do to address this right here at home. And so I think COVID has provided us an opportunity to really think about how do we address these disparities. And as you all know, it's not just about race and ethnicity. Highly tied to race and ethnicity is poverty. And poverty is, in my view, the other social determinant of health after racism. And so when we look at the region now, so Monroe County is the small county there on the top left. Again, you see huge disparities in health outcomes. All right, so what we're showing here is the darker the blue is the lower socioeconomic status. And as you can see here, there's a lot of disparity in terms of socioeconomic status outside of the county. So rural poverty is very, very real. And I think it's something that we don't pay enough attention to here in Monroe County because we don't have the issues that, that poverty and rural poverty raise like they do in the surrounding counties. So when we add to this though, years of potential life lost. This is another way of looking at life expectancy. You see some correlations here between poverty on the left and high years of potential life lost on the right. Again, this seems to parallel very closely with poverty. So poverty and having a higher number of years of potential life lost are highly correlated in our region. And I show this because it's important that we think about disparities in every possible way, in terms of gender, gender equity, race, ethnicity, poverty, disability status, educational status. There are so many ways that we need to look at disparities. And I think we are well poised in this county to think very broadly about it. But the topic of the day, of course, is COVID, and public health enemy number one is COVID. And I always have this graphic because I think as we go through this crisis, it's very tempting to start pointing fingers at a whole bunch of, quote, other people, other parties, other constituencies, other stakeholders, and say, they can do differently. And the reality is that we're all fighting a common enemy, which is this virus and this pandemic. This pandemic is the enemy to me. It is the reason that all of the challenges that we've experienced and all the opportunities that we must seize are now before us. But we've said it many times before that these disparities are not new. These disparities have been long standing, and I think COVID is now just bringing many of those to light. I won't spend too much time on this other than to say that we are in the home stretch, I believe, of the COVID pandemic. On the top left are cases. On the top right is positivity rate. On the bottom left is hospitalization rate in blue, ICU rate in yellow, and in the bottom right is the death numbers per day going back to the beginning. And in every regard, things are turning up, things are improving. We are now seeing the impact of the vaccine. The impact of the vaccine is felt most greatly in the older demographic, 70, 80, and 90-year-old individuals. We are now seeing the mortality rate plummeting in that demographic. We have a long way to go, but thankfully having prioritized nursing home residents was the right thing to do. That is how we have greatly diminished, thankfully, the number of people that we are losing to COVID today. So this is a little bit complicated, but what I'm showing to you here is a picture of the age breakdown by group, by month, going back to the beginning. I show this to show us several things. Number one is that it's very hard to see the earlier months because those months are dwarfed now by what we saw as our surge here in Monroe County in November, December, and January. And then the other part I want to show, particularly in the more recent months, is this sort of bimodal picture. And you can kind of see it there in November and December, but there were large spikes, relatively speaking, in the 20s. And then we saw a larger spike in the people in their 50s. And this has sort of persisted throughout the entire pandemic. And the way we read that is that the 20-year-olds are, really the reservoir for spreading COVID across the community. And we believe that because the numbers of cases among people in their 40s is relatively low compared to the group of people in their 50s. And so the way we interpret that is that the 50-year-olds are generally the parents of those 20-year-olds. And it has skipped the 40-year-olds, oddly. And so this is why we are very concerned, or have been very concerned, about spread from the younger generations to our older generations, is because we've seen it pretty clearly in households. They seem to travel in households, even though the transmission rate within a household is probably no more than 12 to 15%. There is clearly an association between social gatherings and households. This is another way of looking at the age breakdown. What I will say that is somewhat interesting, or very interesting to me, is when you look at females in their 20s and you look at the race ethnicity breakdown of cases among females in their 20s, in March, April, May of last year, it was predominantly 20-year-old females of color. When you look at October, November, even September of last year, when you look at the 20-year-old female breakdown, it's primarily white 20-year-old females. I think that is a reflection of structural racism, to be blunt. We had many 20-year-old females of color working in healthcare, working in frontline places, and nursing homes. And we still see that today. I think that's a reflection of income inequities. That was unfortunate. That is unfortunately probably the match that set off all of the mortality that we saw, unfortunately, with regard to nursing homes early in the pandemic. This is also a little busy, but what I'm showing to you here are COVID, crude, and age-adjusted rates. So the crude rates are crude for a reason. They're not a really good way of making comparisons between different groups, demographic groups, where the age distribution is different. And we know that to be true when we look at race ethnicity. The composition of the various age quartiles, if you will, within those race ethnicity demographics is not the same. And so when we do age adjustment, we're more able to compare groups that have different compositions in terms of age. So on the top left is age-adjusted case rates. So in blue, you have white non-Latino. In orange, you have black non-Latino. In gray, you have Latino. And in yellow, you have other races non-Latino, which is predominantly Asian. There are some mixed, there are some who did not indicate, but the majority of the yellow other races is Asian American. So as you can see, in terms of the age-adjusted rates, Latino is the highest in terms of age-adjusted rates of COVID, actually followed next by other races, and then Black non-Latino, and then white. When you look at the hospitalization rates, though, things start to look a little differently, where Black individuals have the highest age-adjusted rate of hospitalization, followed by Latino, followed by Asian or other, followed by white. And then when you look at the death rates, again, look only at the age-adjusted because I think that's the most instructive. Latino is number one, and it is at least twice that of white and almost 3 times that of other races. And then Black is also disproportionately higher than among white and other. And so this is a statement of many, many things. One is when society places people in circumstances that are more risky in terms of contracting the virus, it should be no surprise that there is a higher age-adjusted case rate in that demographic. And so very early when we said quarantine or isolate, that is a luxury, that is a privilege that not everybody shares equally. And so it should be no surprise that if a family lives in a home where there's a higher number of individuals per household, it should be no surprise that the ability to isolate or to quarantine is different. Work from home is not a benefit that is distributed equally across our community either. And so a whole host of reasons from a purely social standpoint that make this COVID infection rate something that is not distributed equally. Hospitalization rates are a reflection of the disparate outcomes and disparate risk factors in different groups. And then death rate is it follows suit. So there's a lot to unpack here. I think it's important that we understand these data as we look ahead to vaccination. Unfortunately, we do not yet have a lot of the data that we need, but that is certainly something that we're working on. I think it's also important that as much as we focus on race ethnicity, the leading risk for mortality from COVID-19 is by far age. Age and age plus nursing home is the strongest predictor of a poor outcome for COVID-19 here in Monroe County as it is across the state and country. But when you look at congregate settings like nursing homes and assisted living, pretty consistently throughout the pandemic, they have represented 75% of all who we have lost to COVID. And I think when you look at this, I think it's good that we are focusing on this population. I think we have more work to do working to ensure vaccination equity among staff in nursing homes. I don't think we have that anecdotally from what I am seeing. I'm seeing that the rates are improving. I will say that I have many patients who are nursing home employees, and they are very unsure about whether to go ahead with the vaccine. So we have a lot of work to do. And I want to close with something that I feel very strongly about, which is that we have education inequity. When we look at the proportion of Monroe County students broken down by race and their access to in-person learning in some fashion, there is a stark disparity between Black, White, Asian, and Hispanic children, students in our county. When you look at the school districts that serve a predominantly Black student body, there is a much higher proportion of them who are fully remote in orange. And obviously that is in many cases the city. Very, very few, relatively speaking, have access to some form of hybrid or in-person learning. When you look at districts that are predominantly white, obviously you can see fully remote is very, very unlikely. Far more people have access to the hybrid mode. And that is also true for the Asian student body. And then the Hispanic students parallel very closely to what we see in Black communities. So with that, I will pause and take a moment to introduce the next speaker, who I think many of you are very familiar with. Phyllis Jackson is the Community Wellness Project Manager for Common Ground Health. In this role, she works closely with the faith community, other organizations, and community influencers to promote health, wellness, and self-care management. She focuses on alleviating healthcare disparities through a variety of outreach efforts. Deeply involved in the Rochester community, Phyllis Jackson volunteers for numerous community-based organizations and sits on several community boards and committees. In December of 2020, she was appointed by Governor Cuomo to the New York State Vaccine Equity Task Force. This group is charged with breaking down barriers to COVID-19 vaccination and with ensuring that there is equitable distribution of the vaccine across the state. So without further ado, I want to introduce Phyllis Jackson.
Thank you, Dr. Mendoza, and thank you, Team Pam, Dr. Lucas, and the group for having me. It's a pleasure to join you today. Dr. Mendoza has so laid out the numbers for us and given us a really clear picture, I think, of what is going on around hospitalizations, around deaths, around infections in our county. And I want to look at something he said that is key. And I think that as we're looking at how we're going to increase vaccination rates, how we're going to achieve herd immunity, has to do with all of how we approach issues that we're having. He made a point that one of the problems that we know when we look at social determinants of health, that healthcare in itself, direct healthcare, is really not the greatest determinant of healthcare. It is the other things. And one of the things that he said were two things: poverty and racism. And so as we're looking at, it's no different in this COVID environment in which we're in this particular epidemic that we're looking at, or pandemic that we're in, looking at COVID-19. He said this. He said that we all have a common enemy, and that is COVID-19. And so when we're looking at that, I think that one of the things that we have to begin to evaluate is that the perception of the predominant group or the minority group. And I think that what we see in the minority groups is that the common enemy, it's not seen as a common enemy that we have to fight in the same way. And that's due to a lot of the mistrust that has happened throughout centuries, the medical malpractice, medical misuse, our history of health inequities and health disparities. And so it's not seen so much as a common enemy. Certainly is an enemy, but very often in brown and Black communities, it's not seen as our enemy. It's seen as an enemy that's out there that's being put upon us. And so how it's perceived is a different way. And so therefore, how we actually begin to talk to people about this and engage them in the work of preventing COVID, or treating, or even in the vaccination process. And so we know that COVID-19 has affected Blacks and Latinos harder than any others. The numbers have shown that. Black residents are nearly 2 times as likely as white to test positive for COVID. and Hispanic residents are 1.9 times more likely. And we saw the numbers that says they're more like, who's more likely to die of COVID-19? That is Blacks and Latinos in Monroe County. And what we also know is that vaccination of Blacks and Latinos are lagging behind white residents. And so we asked the question why. One of those is because we perhaps are not viewing it in Black and Brown communities as a common enemy in the same way. And so we look at, well, why are they lacking behind? Then we go to social determinants. Is it because there are not enough doctors? Is it what we see is that some things are contributing to this that contributed to poor health outcomes in Black and Brown communities as a whole. Transportation, lack of transportation to get there, the digital divide, technology, the ability to be able to go online, to call, to sign up for vaccines, to understand the language, to be able to do that. Time to get to the location, the lack of flexible hours, locations that are located in our communities. So these are things that are impeding perhaps people of brown and Black communities from actually getting to vaccines. And so we have to look at efforts to expand access to the vaccine. One of the task force charges to us is that we want equitable distribution of the vaccine. But what we have to also understand is that equitable distributions, and now the numbers are going up of how many doses of vaccine we expect the doses of vaccine to grow in number as Johnson & Johnson has been added, and we are expecting that we will have other vaccines be added. President Biden said in his address the other night that he hopes that by May, which is an ambitious date, May 1st, that everybody would be eligible because we will have other vaccines that are available, right, to vaccinate people. But because we have more vaccine available does not mean that people are going to take it. And that's where we're looking at right now. Vaccine being available, certainly all of these barriers, we're looking to address those. And we're looking to expand access to the vaccine. And we're doing that with the pop-up vaccine clinics. And those that are done are one-time, they're assigned one-time only events that are done primarily in churches and rec centers and those kind of libraries, those kinds of places. We're offering help over the telephone through 311 and 211. Rochester transit system is not charging fares from the transit center to the new Hawkeye site for vaccinations, which has opened up on St. Paul. And so we're looking at ways to expand access, and we're doing all of these things so that people, brown and Black people, do have access to the areas and the facilities that are doing this. But there still remains this idea of vaccine hesitancy among brown and Black people. It is understandable due to many of the things that Dr. Mendoza has spoke about, which I've said, medical racism, such as the Tuskegee experiment. There's also concerns about the speed of vaccine development. We know that when we get to the science of it, that science had a high head start, that vaccine technologies had been in development for over 2 decades. And so we have those facts. We know that Blacks and Latinos play key roles in the research on COVID vaccines. For example, Dr. Corbett, who helped develop the Moderna vaccine, and Dr. Angela Branch, who is at the University of Rochester, researcher that is working on the AstraZeneca vaccine. And so we are working on those efforts. And what I think that is missing is that the science is there. And so one thing is getting the science to the people through that, to that effort. Part of what Common Ground has done, working with University of Rochester and the Vaccine Hub, is to begin to, we've established a speakers bureau. And so we have clinicians, we have people that are in studies, we have people that are sitting on community boards that are going out and can go and have conversations that will give us the science, that will give us the data that we have gathered and what we know is going on with COVID and the numbers. And then we have table talk conversations where we are encouraging people that know about this to have small group conversations. And these are really, really helpful with families. and members of families and close friends and people that are not in a big group but have questions, and we have to be available to be able to sit down and have conversation with 4 or 5 people and talk about the data, talk about the science. It's been a great tool that we've been able to utilize in faith communities on bringing faith groups together and smaller groups to talk about the vaccine. And then, we're doing what we're calling empathy interviews. What we are failing to do, I think, to a great part, is listen. And so the empathy interviews are meant to listen at what people have heard about the vaccine. What do they think about the vaccines? What do they think about COVID? What do they think about the way it's been handled? What are they thinking? And our goal in this is to listen so that we can begin to address their concerns. One of the things that I think we're looking at and finding out as we do this empathy interviews and talk to people and listen is that most of the time, the science is not as much in question. People know, and we're hearing, okay, I heard it prevents COVID and it might be good for us and it helped prevent spread. We're finding that more and more people are not doubting that. They don't doubt the science. They're hearing that Black and brown people were involved. They're seeing doctors, they're seeing the PSAs, they're seeing the doctors talk about it. But what we are overlooking is that quite a few of people that we're talking to, it is not a scientific issue, it is an emotional one. It is an emotion built on fear. Now, the fear may not be directly involved with the vaccine, but there's a fear. And so I've talked to people, said, how do you feel about it? Well, I believe it works and we should get it. Well, have you thought about getting it? No. Well, I'm going to wait and see. Why are you going to wait and see? Is that, well, I want to see because we don't know what the long-term effects are going to be, and we don't know what's going to happen. And we know what happens with Black people and brown people, that they start off stuff and then down the end, it ends up bad for us. And so there are fear. And when we have fear, fear begins to be your reality. And if that is your reality, that there is something that's going to happen, your response is more an emotional one. So in listening to people, we are able to hear what they have to say and to hear their fear and to say, okay, it's valid. It's okay. We understand that. And then if we give them permission to be able to share their fears, to share their feelings and their concerns, not so much around their concern around the vaccine and the science, but about how they feel about it, and to be able to delve into that. So we find that this is happening, especially people that have underlying conditions. So we find that with people with cancer, people that have MS, people that have other underlying conditions and health concerns, their thing is based around the science may be real. I understand the science. I know what they told me. I know what that means. But what about me? I'm already worried about my condition. I'm already concerned about where I am. I'm already not getting perhaps the best healthcare I think I should. I know that there's racism going on. Look at what's happened with Daniel Crude. Look at what's happening with the police shootings and all of that. And what that does is stirs emotional responses that happen that make the common enemy no longer a common enemy. And so as we're listening in these empathy interviews, and we're listening at these table talk conversations in these speakers bureau, we're asking people to say, what is it that you are feeling? What is it that's impacting you, impacting your thought processes, impacting your emotions? And we're finding that as we're able to do that and allow people to be able to talk about it, then we can talk about the science. We can talk about their concerns. We can bust some of those myths that they have bought that support their fear. All right, we have a saying that, we're not given a spirit of fear, but a power and of love and of sound mind. And so then we're able to, once we look at the fear and talk to them through these interviews and listening, we're able to go back and say, okay, these are some facts. How do you feel about this? How does that fit in with the way that you're feeling? And so I think that as we move forward and looking at ways that we engage, that the vaccine becomes more readily available, that we're also beginning, not only would it be available, that the arms are going to be there for us to vaccinate. And I think that looking at that and listening to people, providing the things that we know we need to provide, transportation, easy access, bridging the digital divide, providing the facts and the figures, getting people out there to talk about it, making it available in our communities. And this includes rural communities as well, because we find again that we're doing these interviews and we're asking people in rural communities, and we're finding the same thing, the same responses pretty much in the rural areas that we're finding in the city. But I do think that as we begin to look at this and understand that people very often are responding in a more a emotional response versus I know the science response. I know the science, but I may know the science, but if I'm emotionally upset, if I'm emotionally in this place where of miss and feeling some kind of way about something that may not have anything to do with the vaccine, then it blinds me to how the vaccine could work to my benefit. And so as we proceed through Common Ground, through our work of reaching out in the community, providing access, putting feet on the ground, knocking on doors, talking to people, listening to people, and providing assistance to people to have access to vaccine, that we also listen to people into their fears, into their concerns, and then we begin to address them on an emotional level as well as a factual and scientific level. And that's the end. Thank you. So, Pam, back to you.
Hello, thank you so much. I just want to, first of all, thank you, Dr. Mendoza. Thank you, Ms. Jackson, for your just so much great information and giving us a really great view of what has been going on with health disparities, and really how COVID has been shining that light on health disparities. I appreciate it very much. I want to make sure that we get you've been getting questions here in the chat box and Q&A. So I think what I'll do, if this works okay for you, is I'll just pull up the questions as I saw them come in, and I'll make sure that they get to the right people as well. So Dr. Mendoza, while you were speaking, there was a question about how to get the vaccine to the rural poor. It says, I know that Common Ground, and this might go to Ms. Jackson as well, I know that Common Ground targeted zip codes in the city to help with disparities, but are there any plans to target the rural poor communities?
Yes, absolutely. When we talk to our counterparts in the rural counties, it's very clear that they have very different issues. The biggest challenge, honestly, is the supply. We have not gotten enough supply to vaccinate the population, certainly, but even more so in the surrounding counties, they lag behind Monroe County because they have much smaller allocations of vaccine, and obviously they have a lower population than Monroe County, but even that notwithstanding, they're not getting enough vaccine. And so part of that has come from the way in which the vaccine has been distributed across the state, wherein there are regional hubs, and the regional hubs are responsible for the various types of allocations, but then the allocations have very prescripted ways in which they should be delivered. So depending on what type of a vaccinator you are, if you're a federally qualified health center, if you're a hospital, if you're a health department, that determines one level of who you can vaccinate. And then there's the added layer of what you need to use to administer to the individual. Whether it's Pfizer, then you have to do you use that for 65 and older populations, for example, depending on where you are, and there's this complicated web of who you can vaccinate with what. And the rural poor and the rural counties in general have been left out of that equation. That sort of thing works well for things that we have in the city here, with convention center, we can take thousands of people a day. That's not something that a rural community has the luxury of being able to do. So when they have to open a vial of Moderna, they've got to use it for 10 individuals, otherwise it goes to waste. And so they've had to, open up a vial, and they have 65 or older individuals there, and they vaccinate as many of them as they can. But then if you have somebody who's 25 who is a cancer survivor, you cannot use that supply for that individual, and that person goes unserved. Whereas here in the city, we can pivot very quickly. So, I mean, these rules are hopefully going away. We have some guidance from the state indicating that it's going to get looser next week. But that has been a major driver for the disparity among rural poor today.
Thank you. I'm going to now give a question to Ms. Jackson. Ms. Jackson, here's the question. Where are you able to actually set up shop and do the important outreach that you were talking about? It says here, as an outreach worker, I know how challenging it is to meet with people, no health fairs, remote church, etc. Love the idea of empathy interviews. And who and where are you doing those? And are you working with nursing home staff? A lot of questions in one.
The outreach is definitely different than we're used to doing it. I mean, we are no more health fairs, no more events. We're not tabling. But I'll give you a good example. Week before last, we getting ready people. We had a week for people in certain zip codes in the city to sign up for the new Hawkeye site, which is the FEMA state site. And so what we did was we put the word out. And so we had Ibero, we had organizations at ABC, all different types of organizations. And we put the call out and said on our hub and said, we want to get some feet on the ground if people are willing to go out and knock door to door. And so people were able to contact us and say, yes, we'd like to volunteer. We talked to sororities, we talked to fraternities, any kind of group, and said, do you have people, community health workers, Lucinda Calindres from the Community Health Workers Association, Jay Antonetti from Fidelis and others said, yes, we have people that are actually going out, talking to people that are still have feet on the ground, and we're willing to go out. And so what happens, we had a cadre of people that went door to door and did that work. And then having rec centers and libraries, people there, station volunteers to be able to help people, for people to go in and be able to go in and get help, going online, setting up appointments. We did that in faith institutions. We had through IHMC a group of people that people could call and was going online making interviews for people. So even though we have not the wide bandwidth to do a whole lot of actually feet on the ground because of the limitations, we have been able to do that. The empathy interviews we are doing mostly online, on phone, but virtually. And we have been doing those with all kinds of groups. We have empathy interviews for groups that are for rural communities. And we've been able to actually talk to people in rural communities and ask us the same questions that we're asking, and what are the barriers. And there, you know, we have a very population in our rural communities, people, migrant workers, people that are perhaps maybe undocumented, that have some other fears, people of different religious beliefs. So yes, we're doing those. We're doing those on Zoom. We're doing them with senior groups. And so we're asking any group that would really like, we're looking for young people. We have some college, we're doing them with college students in that group that Dr. Mendoza was talking about, those 20 somethings. And now we're looking at those 40 somethings. We're trying to hit every group, and we make it available. And we have people out there, ambassadors, that are saying, we have these empathy interviews. We would love to talk to you about how you're feeling about vaccinations and about COVID. And yes, one of the targeted groups that we really want to talk to are healthcare workers and nursing home staff. We were approached by a group and said, we really want you to talk to our group because less than 20% of our people who are doing direct care, Black and brown, and they are less than 20% of them have taken the vaccine or even want to take it and express some kind of fear or hesitancy. So yes, we are focusing on all those groups that we're seeing that are not responding, and we're not getting the numbers that we hope to get. And we're doing a lot of it through faith communities as well.
Thank you very much for that. I have another question here that came in while Dr. Mendoza was talking about the deaf community. So the question is, how are we also reaching out to the deaf community who also have similar issues, lack of access to audible information, access to transportation and internet, and she also says pop-up clinics can be a challenge as we need to do community outreach for them as well. So if you could.
Yeah. Yeah, admittedly, we're not doing very well, I don't think, with the hearing and non-hearing population. The education that we have, as you know, is not interpreted into ASL often at all for when we're trying to deliver this outreach. And so the pop-up model is challenging. It's challenging for many, many reasons. It's important, but no, this is an area that we need to do a better job with.
And I'm going to give you one more here, Dr. Mendoza. Do you know if anyone receiving cancer treatment can receive a vaccine? And can you, and sort of two-part question, can you also talk about any concerns between screening results and vaccine side effects, especially with mammograms? Do you have it?
Yeah, so 18 and older, if you are receiving treatment for cancer, then yes, you are eligible. For mammograms, so the guidance is that you should not get a mammogram within 2 weeks of a COVID vaccine. The reason for that is because the COVID vaccine elicits a reaction, as it should, in the lymph node that's nearest the injection site. So that's typically going to be in your armpit on the same side. And so what can happen is that armpit, the lymph node in that armpit can grow, can look very concerning. And when you get a mammogram, or more likely an ultrasound that often results following a mammogram, that will look like cancer. And unfortunately, since it's unlikely to be cancer in that setting, we unfortunately still have to go ahead and biopsy that, which leads to a lot of anxiety and obviously the procedure and the side effects and all of the things associated with that. And so mammograms in general are not urgent. So we ask people to, wait at least 2 weeks after a vaccine, or ideally get it before the vaccine.
So Ms. Jackson, another question about empathy interviews. When it comes to the empathy interviews, what is the importance of having Black and Brown representation leading that effort?
It's very important because people talk to people that look like them, people that they feel like they can connect with, that they have relationship. Brown and Black people tend to be very relational. And so having these interviews done by people that look like them, that are from their community, that have an understanding and an empathy toward them, and is huge. And so we do have tried to get people that do these interviews, the ambassadors, to actually reach out to the populations in which they are, communities in which they're a part of. And that has shown to be most effective. I want to make a comment on something else. And Dr. Mendoza said something when the question came about cancer patients, about mammograms. One of the things that when I talked about not being able to see it as a common enemy, and also how myths get born. And so I don't think that we haven't done as good a job as we could have done on alerting people of possible things, of things that are happening. So we get a lot of myths are born because people get normal side effects from things that we expect from the vaccine. But because we're not alerted, it eventually it gets, the past in school, you tell somebody something at the beginning, and then at the end, it's a completely different story. And we have not done a good job of preparing people for the potential side effects that come just as a natural result of having a vaccine. And so by the time people get it and it gets passed on and passed on and passed on, people are saying, we can't, no. See, that's why they don't do it. That's why I'm waiting, because they're doing that to Black people. They are not telling Black people that. They're, because they're hearing it from other Black people. So I think that we have to do a better job of that. And, one of the questions that has come up was with people with cancer that are having mammograms, is this whole question about, well, they're doing it. And one of the myths that has come out of this is that it causes cancer, breast cancer. and the higher cases of breast cancer in Black women. And so it boils down to, here we got another myth that's come up that people don't understand, that really it's not, you just need to wait for 2 weeks. But we're not doing a good job when these things come up of having these explained and giving people information so that we can allay their fears. Cancer is an emotional thing. So therefore, when I hear anything that might make it worse or make it better, then that causes me to say, okay, I'm not going to do it. But I think that that's a good example of not, people not getting information. We've had the same thing with pregnant women. Can pregnant women, well, if I get it, my baby's going to have COVID, or am I going to have, cause me to have miscarriage, and those things. So I think that we need to do a better explaining those kinds of things. Yes, it's great to do all the logistical stuff, is absolutely necessary, but so much of this are around emotions of what's going to happen with me and my body and my life and my health. And I think we need to do a better job of helping people understand these things that are natural to this process, and say what we know in the long run. What we don't know, we don't know. But this is not just for this vaccine. This has been for all other, pretty much everything else that comes out new on the markets and other vaccines. We don't know until we've done it for a long time. And we're learning more and more as time goes on. And I think being honest up front about those things will be very helpful in helping people overcome this hesitancy.
All right, thank you. Dr. Mendoza, here are a couple questions. What are we taking away from what happened with the nursing home residents, and how could that have been managed better? And then there's actually, well, I'm just going to ask you that one now because the other one's a little bit different from that question.
So very early in the pandemic, one of the concerns I had, because nursing home residents don't themselves tend to circulate very much outside of nursing homes, the biggest liability in the nursing homes was the staff bringing it into the nursing homes. And one of the requests that I made, which it didn't fall on deaf ears, but it was so out there that nobody really could take it seriously, was to limit staff to working only in one nursing home. We know because we did a lot of contact tracing that many of these individuals have multiple jobs working in multiple nursing homes. And so it was unfortunately a perfect storm. We didn't have enough PPE at the time. And so that was another barrier. Not that that would have mitigated all of the risk, but it should have helped. And then there is a better PPE education. So even when a nursing home had access to adequate supplies of PPE, consistent and proper use was something that was a struggle for many individuals. And so I think those three, trying to limit the number of nursing homes a staff person might work in, which is an economic and a social justice issue, frankly. That was not something that was going to be easy to fix. That is a result of many, many years of, again, a structural component to racism. And I think it's something that we see in healthcare in general. And we're not going to fix that unless we recruit more people of color into higher levels of education that will propel them into careers like medicine and other, nursing and other fields like that. But as well, even in the entry level, we don't have equity and access to that level of education as well. So, what we saw in the nursing home again was a melting pot, unfortunately, of many, many years of problems with racism in our society.
There are a couple questions. I'm going to ask you again, Dr. Mendoza, a couple questions about plans, vaccination plans here. So there's one asking about the plan to vaccinate homebound patients, another about vaccinating immigrant farm workers. And so I'm just wondering about, different populations that are maybe more difficult to reach. What are the plans for vaccinations?
Sorry. I've said many times before that this is the largest public health undertaking of our generation. And none of us have experience vaccinating this many people in such a short a period of time. So in some respects, we are learning as we go. But we can borrow a lot from other experiences, whether it's regarding other vaccinations or access to other healthcare services in general. And I think the lesson that we're learning is that this is very much like the adoption of new technology, in that early on, the people who are likely to adopt a certain technology are going to be different than the people who are later and much later in the adoption of that technology. So when it's about accepting a vaccine, assuming we distribute it equitably, which we're not doing, we still have to look within the early adopter category and say those who are early adopters are less likely to have major concerns with the vaccine, which is why they're early adopters. They do have different demographics with respect to access to technology and computers and telephones and language and transportation and all of that. When we get to later stages, though, we're going to have to look at how we deliver the vaccine. One of the challenges right now is that we still have these rules. Migrant farm workers are not included in eligibility criteria, even though the CDC and ACIP have said that they should be. So New York State did not include them. That's a failing of our guidance here in New York State. The location of giving vaccines is going to have to evolve as well. These mass vaccination sites are not ideal for a lot of people. They are important. We are prioritizing them first, and I support that, because we've got to get to herd immunity quickly. And the quicker we get to 40%, the quicker we can get to 60% or 80%. We don't want to be focusing on those communities that are going to be really, really a struggle in the first couple of months, because we're not getting to 20% very quickly that way. Once we get to 20%, and we've gotten to 20% now, we will start to see the benefits, and we already are. But we can't leave other people behind. And so we're going to look at how do we vaccinate in primary care practices next. We haven't had the vaccine supply to do that effectively. The Pfizer vaccine, which we have a lot of right now, is not very well suited to primary care practices. Once you open it, you have 6 hours to use it, or it expires. For Moderna, you've got 10. You've got to use the 10 within, I think, a day, or you have to waste it. Johnson & Johnson is the next one. We have gotten a very small shipment of Johnson & Johnson. It's a one-dose vaccine. It's the one that we want to use for hospitalized patients, because they're leaving the hospital, and so we don't have to worry about trying to bring them back to the hospital to get the second dose. Homeless individuals, incarcerated individuals, those are the people that we want to offer the one-dose vaccine to, because it is more effective than one dose of Pfizer or one dose of Moderna, because getting the second dose in those settings is more challenging. So we have to continually retool our vaccination program efforts.
And I think we can sneak in one more question for Ms. Jackson, if that's okay here. The question is part of the reason we're not getting the numbers we're looking for because people are having trouble with registering? In my experience, that's the biggest concern with the Black and Brown people I have interacted with. That's the question.
Certainly registration has been a big problem. There is a big digital divide, we know that. And the lines, one of the reasons that, the state was, very, one of our main concerns was that people have the ability to be able to access, signing up and registering to get the vaccine. We want to make sure that it's equitable, but if it's there and they can't get a sign in, they can't get on, they don't know how. So one of the reasons that, and we hear that a lot. So that's one of the reasons that we have kind of looped in these ideas of, we've added 311 and 211, though people are saying they're up 2 or 3 o'clock in the morning still trying to get appointments and get registration. That's really, really hard. But having the expanded sites is going to be helpful, because there will be more slots for people to actually sign up, but also having 21131, having people at the rec centers, having people in the libraries to be able to help people where they can actually go in and get help to sign up, having groups like IHMC where we have people that will register people. that they call us, we call in, and we go online and do the registering for them. And so, and then, you know, loop them with their information and all of that. So I agree that we are, among brown and Black people and among refugee populations as well, that we're having this same issue, is that, you know, access to getting an appointment, because we had such a limited supply. And Dr. Mendoza has said that throughout. The limited supply really has been a major contributor to a lot of the other factors.
Yes.
And so, because we didn't have a lot of vaccine, then the number of registrations were really, really small. And so it was very hard to do it. But it is opening up now, and we are very hopeful with what we're putting in place, and talking to people and having access be more readily available, that we'll have a better uptake.
Thank you so much. Oh my gosh, there are so many more questions. I even have many more questions, but our hour is up with both of you. I just want to thank you, Dr. Mendoza and Ms. Jackson, for all of the
Thank
work
you.
that you're doing right now in our community. It was really a pleasure to have you here today. We will be, just so everybody knows, we'll also be having another conversation next month. It will be on April 9th. And we'll be actually talking about COVID some more, but COVID directly related to cancer. So I look forward to, I'll be passing out some information about that. But thank you so much. Thank you to everyone who attended, and thank you to both of you as well.
Thank you so much for having me.